Every minute, someone's life takes a terrifying detour, not down a dark alley, but into the sterile, bright halls of healing. They walk in seeking care and find themselves plunged into a nightmare. Most malpractice claims in hospitals are related to surgical errors, whereas most claims for outpatient care, which accounts for more than half of the paid malpractice claims, are related to missed or late diagnosis. Now, before you raise a pitchfork at every white coat you see, let's be clear. This isn't an indictment, it's a revelation. Because the truth is, any provider, any nurse, any human being capable of brilliance is also capable of a mistake. This is about understanding why and using that knowledge to build a safer future for every patient who walks through those doors. Welcome to FHEA's Scrubs and Subpoenas, Tales from the Witness Stand, a podcast where we'll peel back the sterile sheets and delve into the real stories of medical malpractice. Each episode, a cautionary tale, a blueprint for change, a reminder that even in the darkest corners of human error, there's a light. The light of knowledge, the light of empathy, the light of a future where healthcare becomes not a gamble, but a guarantee. So join us as we dissect the mistakes, illuminate the flaws, and ultimately learn to heal not just bodies, but the very system itself.
Hello and welcome to another episode of Scrubs and Subpoenas, Tales from the Witness Stand. I am your host, Jonna A. Neal, and joining me is expert faculty and expert witness here as Dr. Sally Miller, my very cool co-host. Thank you for joining me again.
Always a pleasure.
Awesome. So if you are just tuning in, hopefully you're not just tuning in for the first time. This is a really fun podcast, really interesting podcast, and where we are going to listen in to real cases, real medical malpractice cases that Dr. Sally Miller has served as an expert witness on. And I should say, I think I forget to say this, you can be an expert witness. I never even think about this, to be completely honest, on the plaintiff side, right? Or the defendant side. So I actually had the complete wrong assumption when we first started doing these podcasts that naturally you're an NP, you're always defending the NPs, but that's not always true, right? And that's not always true for an expert witness. You don't always get called on to defend the person that fits your role, right? That's not true.
That is definitely not true. We can be contacted by either plaintiff or defense. And, of course, serving as a plaintiff's expert witness does not make us popular in the professional community, because there is a school of thought about, banding together and, having that wall. And I guess, being popular, thankfully, has never been my priority. But if there is a case where an NP has clearly deviated from the standard of care and it led to an adverse outcome for a patient, I don't have any qualms at all about testifying about that, because we all need to be held accountable. We've fought for so long as a profession for autonomy and independence and prescriptive practice and analogous reimbursements, that we still haven't gotten yet, but we're getting there. We've been so long independent. We want to be respected as primary care providers. We want to be respected and acknowledged as independent providers. And that's awesome. And we deserve that. But along with that is the responsibility for implementing that role appropriately. It's kind of like, was it Spider-Man? Let me quote a brilliant here. Spider-Man that said, "With great power comes great responsibility."
Yes.
And the spider came out of his wrist.
Peter Parker's uncle who said that.
Yeah, okay, that's right. It was his uncle who said that. But it's so true. We want this independence. We want to be freestanding primary care providers, okay, but then we are accountable to a knowledge base that is appropriate to do the job, and we are accountable when we mess up. And so I don't like to see any case where anybody gets hurt and anybody messes up. But if it's an NP who clearly deviates from the standard of care, I have no trouble at all testifying to that. And I also have no trouble telling an attorney, I can't support your position here. And believe me, it has happened on plenty of occasions where even attorneys with whom I have worked on other cases will come to me with a case and I'll look at it and say, no, I can't, that person didn't do anything wrong. There's no deviation there. I can't support your position. There's one attorney in particular who I really enjoy working with. He's very smart. And in the scheme of plaintiff's attorneys, he's actually very nice. Even when I met him when he deposed me as a defense witness,
Oh
and
my God.
for a couple of hours, he was trying to, just trying to elicit from me something that I never said because it didn't happen. But after that case, he reached out to me to review one of his cases, and that was almost 10 years ago. And since then, there have been many cases, and some I can support, and there have been some where he clearly is representing a plaintiff who has been on the wrong side of a deviation of standard of care. And then, like I said, I have no problem holding anybody accountable. But if the NP didn't deviate from standard of care, I will tell them that too. So I think it gives us legitimacy if you are open to both kinds of cases. Well, by the same token, I have told defense attorneys I can't support you because your client did, deviate and is responsible for this outcome. So it just seems like defense attorneys call me more often. I think insurance carriers, they give names of people they've had successes with. But the last time I counted, because every time I am deposed, one of the first questions the attorney asks is, do I always do this or do I always do that? What's the ratio of plaintiff to defense? And the last time I looked, it was something like 35% plaintiff's work and 65% defense work, just because that's who reaches out. And those are the cases that I can accept.
Wow, that's interesting and really well said too, because I mean, honestly, you're not only advocating for the patient, right? The folks that are on one end of this, but for the profession. And you're totally right. You're absolutely right. And that's important. It's just as important as advocating for the patient. So with that said, I'm actually going to turn it over to you, Dr. Sally Miller, because we're going to get into our next case. And so Dr. Miller is going to walk us through this actual patient case. This is something that she served on. She hasn't told us if it was plaintiff side or defendant side. It is quite interesting to listen along and try to figure out where she was as far as an expert witness, serves on this case. But I'm ready when you are. So let's listen along and follow along and see what we learn here.
Okay. Well, this too is like most cases. This is about standard of care. Did the nurse practitioner deviate from standard of care? And for anyone who may not have listened to another Scrubs and Subpoenas podcast, I want to reiterate that standard of care is not a guideline or, not, the GINA guidelines for asthma or the American College of Cardiology guidelines for hypertension. You talk to an NP about standard of care, and they will usually start quoting evidence and guidelines to you. But in the legal world, standard of care is what the person of a same license or certification, the same type of practitioner with the same level of education, experience, and training would reasonably be expected to do in the same or similar circumstances. And the circumstances matter too. Like just using the example of asthma, yes, we have GINA guidelines, and if you work in an allergy clinic that's affiliated with a national asthma center or just, a high level specialty setting, you will manage asthma differently than if you are an NP in a
True.
primary care practice out in, rural America. We will try to use the best that we can, but especially with an asthma exacerbation, the opportunity that you have available to you is certainly going to be different. So the same or similar circumstances is an important part of that standard of care. So this case is a case about a young woman. This was a 36-year-old female, and she had been a patient of this practice. Yeah, she was young. I know the older I get, the younger 36 sounds, but by anybody's accounting, 36 is a young woman. She was a patient of this practice for at least, I want to say 4 years for at least 4 years going back from the date of the event. So she was well known to the practice. She was well known to this NP. In fact, specifically asked to be seen by this NP typically when she would go in for care. At 36, she too had no real medical history to speak of. The things that were documented in her chart, apparently she had persistent sinus problems. It was not unusual for her a couple times a year to come in complaining of sinus symptoms. About 3 years prior to the events that are relevant now, apparently she had some transient anxiety, and she had over the course of 3 years 2 or 3 different prescriptions for Xanax, but not long term. Like maybe like a 14-day supply or something, like maybe 14 or
Okay.
28 pills. Uh, 1 year, and then a year or so later there was another one. and like that. So there appeared to be some sort of, some transient stressors or history in her world. Um, she had small children. You could see the orders for prenatal vitamins and things like that. But other than that, she had no significant medical history to speak of. So again, I'm going to be referring to the chart notes here because I do want to be very literal in what I present to you, and rather than my interpretation. So her medical history recorded as headaches, which were presumed related to sinusitis. She had HSV1, and she had a documented history of TMJ. And the Xanax, the reason for it was never really clear. There were just brief notes about, transient stressors or something like that, something to do with like work-life balance. Anyway, she appeared to enjoy good health. She was married. She had 2 young children at the time of these events. She had, I think it was a 2-year-old and a 5-year-old. And um, so the relevant piece of the story begins on, we'll say, the 26th of the month, because it was the 26th of the month. I just want to give some time perspective here. She initially early that morning, according to the testimony of her husband in his deposition, they were up early, somewhere between 8 and 8:15 a.m. And she was saying that her chest hurt and it was going up into her neck. Now, this wasn't, there's no recollection of what she said, but this is her husband in deposition testimony later on, that she had chest pain or chest tightness and it was going up into her neck. He was very specific about the next thing, that he remembered that very clearly. Um, they had been having breakfast, I guess, downstairs, and she was complaining about this discomfort. And then she went upstairs for something. And when she didn't come back down, he went upstairs and found her on the floor. He said she had collapsed. She was awake. She was awake and responding to him, but he said she wasn't quite right. And so he called 911. So emergency services came and took the patient and transported her to the hospital, local hospital emergency room. By the time she got to the emergency room, she was fully lucid, awake, alert, and oriented, and described for the people that the emergency room staff that evaluated her, that she had been having these pains or this tightness in her chest off and on. And even in the deposition, you could tell that the husband was gesticulating toward his chest when he was telling the story, because the attorney said, "Did your wife make that gesture or did you make that gesture?" And he said, "My wife, when she was explaining it to the doctor, used the gesture." So she was in the emergency room. She had an EKG. She had cardiac enzymes. She had, a CBC, a metabolic panel. The usual suspects when you work up something like that. And while she was there, she improved and the pain went away. Her ECG was read as normal. Her cardiac enzymes were negative, and the rest of her studies were unremarkable. So she was discharged to home, and the presumptive discharge in the discharge paperwork, it said presumptive diagnoses, stress or gastrointestinal. So she was discharged to home with instructions to follow up with her primary care provider within 1 to 2 days, which is, everybody is instructed. You could stub your toe and go into the ER and they'll say, follow up with your primary care provider. Like, it's like
They
a
do.
standard line. Yeah. It's sort of actually a joke. Like, it's like whether you're in the hospital for 2 months or 5 minutes, the last thing somebody's going to tell you on the way out the door is to follow up with your primary care provider.
This is true.
So she was advised to do that. But she was advised presumptive diagnoses as stress or gastrointestinal. So this family did appear to be really health conscious. You could tell by her records with this primary care physician over the years. She had her checkups, she had her well woman exams and things like that. So her husband took her home. He met her there, like he had their 2-year-old, but she was in the ambulance and then he went to the ER and then they left together. And there was a lot of questioning in the deposition about, was she in pain when she left? Was she still having pain or was it resolved? And it appears that by the time they left the emergency room, she was feeling better. She wasn't having any more pain or radiation to her neck. So her husband took her home and then he dropped her off and he wanted to go shopping because, do you remember Hurricane Sandy, the stories about Hurricane Sandy, right, in 2012? Well, that storm was predicted for the next day or so. So, of course, nobody knew how badly it was going to hit, but they knew a hurricane was coming. So he took her home and then he went shopping. She went home and immediately called the primary care office. This was a Friday. And she immediately called the office and said she would like to come in that day if it was possible. So she got an appointment for later that afternoon. So her husband comes home and they decide that they're going to go out and have lunch together before they go to the appointment. And I framed this in this way because it's important to recognize that she felt well enough that he left her at home, and then she felt well enough to go out to lunch before the
Yeah.
appointment, And so they had lunch, and then they went to the appointment in the primary care office. And while she was there, so she sees her NP, and this is the NP that's being sued. While she's in the office, the NP documents the events, that she went to the hospital this morning, that she had chest tightness and chest discomfort radiating to her neck. The MP didn't have an entire report yet. There was nothing that she could call the ER and get, but she did have the discharge paperwork that the patient had been given, most of which are all those pages of instruction and education and all that you
general
saw.
stuff.
Yeah, but she did have information that the 12-lead ECG was within normal limits. She didn't have the graph, but she had the physician report that the ECG was in normal limits, that she was discharged with diagnoses of chest pain, presumptively due to acute anxiety or GI, that a pulmonary nodule, I guess, was noted on her x-ray, and it did not appear emergent, and follow up with that. And that was it. That's all that this NP knew that was available. Well, the info that was available to her. So the NP advised the patient that she should be scheduled for a stress test, and she had the option to either be referred to a cardiologist or to do the stress test in that office. Even though this was an internal medicine office, the physician, I know this physician from years and years ago. He's very, what's the word? Like just sort of, all over things. He does a lot. He does a lot of his own care that some would refer to. And he did stress tests in the office. He was, appropriately trained, et cetera, to do them. So the patient had the choice. You can either schedule your stress test here, or we can send you to cardiology. And the patient chose to schedule the stress test there in the office. So this was Friday. The physician was not there that day. Of course, the physician's out playing golf, but the MP is doing the work on Friday. But they couldn't do the stress test that day. And so they scheduled it for the next Tuesday. And the MP told the patient and documented in her note that if there was any recurrence of pain or discomfort in the interim, to seek emergency care. She also gave the patient like a 5-day prescription for Xanax. So that was Friday afternoon. So the patient goes home. Let's see. That's 10, 8, 9, 30, 31. All right. I'm counting on my fingers again, like a good academic.
Mm-hmm.
That was the 26th. That was a Friday. You have 27, 28, 29, 30, and 31. All right. Friday, Saturday, Sunday, Monday. 26, 27, 28, 29. The patient had no problem. The patient felt like there was no recurrence of symptoms, according to the husband. She was scheduled for her stress test on Tuesday. On Monday, she started to have some symptoms again, but then Hurricane Sandy hit full force and the stress test was canceled. The office was closed and the stress test was canceled. So the 31st, the Tuesday that she was supposed to have the stress test and the office was canceled, apparently there are text messages that she sent her husband throughout the day about this pain in her chest. And, she started getting it in the morning. It was coming and going, and then it was becoming more constant. And the last text that they had was when she said, "This is constant now," and then she had 3 initials that sometimes we put on text when we're trying to think, what the heck happened, And that was it.
Yeah.
The last thing was, "It's constant now," what the heck?
I hate that you just said the last text.
Yeah. So, he husband went home. I don't know why he wasn't there, but he wasn't there for some reason. And, he went home and found her unresponsive and called an ambulance. And so she went to the same hospital where she had been a few days prior, and they immediately transferred her to the big city hospital. And she never regained consciousness. Actually, she was finally declared brain dead.
Oh.
And so what happened to her was that I know it's really sad, she had a
Oh
2-year-old and a
my God.
5-year-old. And as hard as I am, I fill up when like, as I was going over my notes for this case yesterday, I was thinking, gosh, this is a horrible read. She
Oh yeah.
had a dissecting coronary artery. A coronary artery just dissected and basically
Oh my
exploded.
gosh. Is this the significance of the neck pain too? Oh my gosh. Okay, whoa. We had an ECG though.
Mhm. Yes, we
I
did.
I don't
It's
understand. Not that I know that that shows up, but we did that. I don't. I'm
it's
so
not an acute
confused.
MI. It's not an acute MI, or it's not ischemia. It's a
So
dissecting
you wouldn't
coronary
even see
artery.
that?
Yeah, I mean,
So
if you look it up in a book somewhere, it might say, oh, there might be, non-specific SDT wave changes, which anything could
yeah,
be non-specific changes. But yeah, no. So herein, of course, lies the issue.
yeah.
Did anybody miss anything, or was this just horrific, horrific bad luck? So I was retained. Do you know yet who retained me? I was retained by the defense for the NP. And I mean, it's a horrible story when you read the notes. I mean, it just really tears at your heart when you read the husband's deposition about finding her, and of course, part of any lawsuit is it's what's the law, like what's the damages, what's the loss, and so he had to describe what the things that his wife did that he now he needs to pay to have done, or things that he doesn't. And I mean, the husband is an attorney. The husband was an
Oh my
attorney, but in
gosh.
this case, of course, he was just a husband. He
Just the
was just a
husband.
plaintiff and a bereaved husband.
Yeah.
But when reading his deposition, where he talked about his wife, like she was the primary care person for the baby, the kids, and how she did everything, and he just went on and on about what a great mom she was. And
Oh
I
my
mean, yeah,
gosh.
you do. You read this, and I'm sitting there going, "Gosh!" Like usually, it's only animals that can bring tears to my eyes. But as I was reading this, I really, really felt for the man and for the children. For a 2-year-old, she had a 2-year-old and a 5-year-old, and it's hard. It's awful. It's horrible. It's awful and it's horrible. But the question for me was there a deviation from the standard of care? That's it. It shouldn't matter how heart-wrenching it is. What matters is, did the NP fail to do what any reasonable NP with the same or similar experience in the same or similar circumstances would have done? So if you're an NP in an internal medicine setting and a 36-year-old patient comes in that you have known for several years, who has no known cardiac history, and for that matter, no known cardiac risk factors, no dyslipidemia, no hypertension, no diabetes, nothing like that. And this practice tests for all of that, even in young people. Like, it is a very aggressive practice. Like I said, not only did I have the records in front of me, but I knew the physician because I used to live in that part of the country. And this patient didn't have any risk factors for a coronary artery event. So the patient went to the emergency room complaining of the chest and the neck, and was seen by an emergency room physician and had a 12-lead read as normal, and didn't have cardiac enzymes, and didn't apparently have any, clear diagnostic indication. Now, the NP didn't see all of that. The NP only knew the physician report. The NP knew that the physician read the 12-lead as normal, read that the enzymes were negative. She knew that the patient in the office in front of her was currently pain-free, and she offered her the opportunity to schedule with cardiology or to come back. So is that a deviation of
Wow.
standard of care?
Oh my gosh, that's so tricky. So here are my two questions, right? One is, not doing a diagnostic, like imaging, is is that a no-no in this type of case, as far as like, I wonder if that's the deviation. Just in my nurse brain, right? You did these things. Should she have had some type of visual workup in that? And I don't know why I'm still stuck on that Xanax that she got. Would that have masked any type of like additional symptoms or findings that would have been helpful? Oh my
I can't
gosh,
think. I
that is
can't. I
so
can't think of
tricky.
any.
Because there's
So
no
I
there's
mean,
no, like, there's no guidelines that says, like, if this and this and this shows up, you do that, right?
it's a great question about the imaging, but I mean, the standard of care, the
Yeah.
typical approach to the primary care outpatient is if the patient is sitting in front of you and has just been discharged from the emergency room and is currently without complaint, you don't do anything emergently. Nothing is urgent. I mean, even if we tried to order a stat anything, like I know I've ordered stat biopsies for cancer that didn't get scheduled for 3 weeks because stat in the outpatient world is not the same thing as stat in a hospital. So that question really is this patient sitting here on a Friday afternoon who is just discharged from the ER, who is asymptomatic with no particular risk, does it warrant going back to the hospital? Because that's the
Mm,
only way anything's getting done that day.
mm. So that is a really good way of framing it up, and I can only just imagine saying no because everything seemed okay and normal in that moment.
It did. And so I hope that everybody that's watching this has already watched some of our other podcasts, but we did one recently where the NP clearly did not deviate from standard of care. The NP followed standard of care and the circumstances were not especially sympathetic. And so there was absolutely no question. There was no deviation. The case never even made it to court. I mean, if
Yeah.
you ask me, literally, here, it's the same basic premise. There is no deviation of standard of care. Now, remember, this NP doesn't know how it turned out. I'm sure that once she found out how it turned out, she might have, or she probably thought, like,
Oh my gosh.
dissecting coronary artery. Should I have considered that? What did I miss?
Yeah.
Should I have? So for anybody who's listening to us today, ask yourself, how many times in your career have you had a patient with an acute dissection of a coronary artery? For me, it's none. 31 years as an NP, and I've worked in all settings. I worked in acute care for years. I've done internal med. I have never seen an acute coronary artery dissection. I mean,
Yeah.
that's not to say you might not, happen across one every now and again, but they're really, really rare. And there really is not much of a predictor. I mean, of course, after this, and I was very prompted to investigate and learn what I could about dissecting coronary arteries. Again, the statistic is like some ridiculous, like less than 1% in the population.
Wow.
Um, but when it happens, and it's very rare, but when it happens, it appears to happen in women more than men. And there appears to be a menopausal, or like a theory, a postulate about estrogen and female sex
Interesting.
hormones because of the distribution of how these rare cases occur. Also, oh God, I can't believe I'm going to miss the word now. Um, fibromuscular dysplasia. Fibromuscular dysplasia, another most unusual phenomenon, but apparently that's a risk for it as well. But I mean,
Wow.
NPs that are listening, how many of you know that? I probably
Right.
wouldn't know it if I hadn't reviewed this case. And I teach physiology, for heaven's sake. I mean, I know kind of a lot about it, but this is
Yeah.
just like such a one-off circumstance that it's a horrible story, and it's just so sad, and it really does bring tears to even like the most hardened eyes. But the question is, did this NP on that day in that office deviate from the standard of care? Did she fail to do what any other reasonable NP would have been expected to do in those circumstances? And I suggest strongly that the answer is she did not. Now, the plaintiff had an expert, and of course, there was a plaintiff's expert NP who said that she should have considered that diagnosis and she should have required an emergent cardiac evaluation. And I just don't buy it. Again, how many NPs, when the patient was just sent home from the emergency room with a normal EKG and negative enzymes and really no acute finding at all, would think to do that? But now, Now, did the emergency room miss something? I mean, I am not an emergency room physician, and I really don't know the standard of care. I don't know what their knowledge base is. And I'm sure they see, that there's a different distribution of the kinds of things they see. And maybe an ER physician has seen a dissecting coronary artery more than a primary care nurse practitioner. So I don't know if the ER physician, I mean, it really is an unusual symptom complex, chest, neck.
Yeah.
Chest, neck. I wouldn't necessarily think about
Let's
what do
put
you
those
call it?
two things
Anxiety
together.
for that. Yeah. I
Yeah.
mean, but except cardiogenic. So I don't know, but I can tell you that this one, there was an enormous settlement and this is public record, so I'm allowed to say the amount. The patient's husband was awarded $2.5 million for this one,
Wow.
which of course, a significant chunk of that went to his attorneys, and then like reasonable chunks were set aside for trusts for both of their children and everything. And typically with something like that, when there's multiple defendants in the suit, they contribute the relative percentage of liability. Somebody that, I mean, that
Wow.
they all agree on this. The hospital was a defendant, the ER physician, and the company that he works for that staffed the hospital, the NP, and no doubt the practice that she worked for, and they all contribute to the settlement. But yeah, the patient, which there's no, I certainly don't begrudge them that. It's a horrible, horrible, awful story,
It is.
but I still, I would assert firmly that it's easy to Monday morning quarterback, and a lot more MPs after watching this might be inclined to consider a dissecting coronary artery as a differential. It's just so odd. In that circumstance, I really did try to think about what would I do? I mean, the answer isn't what I would do. The expert has to say what a reasonable NP would do in the same or similar circumstances. But just in trying to learn from it, which is hopefully what we all are doing, I was trying to sit back. What would I do in that circumstance where chest and neck, I mean, that does kind of stick in my craw. It's hard to dismiss that as GI or anxiety. GI can be hugely painful, but it tends to be more, substernal
Not
and
like
even up into here. And anxiety, I just don't. Like that neck thing is kind of disturbing, but she had a history of TMJ and that can cause neck pain. So, it is easy. I mean, Monday morning quarterbacking is what we should be doing because that's how we learn from it. And, hopefully don't find ourselves in that position, but just trying to put myself in the position of that NP at that time. I think any reasonable NP that had an asymptomatic patient in front of them that just came out from having lunch out with her husband to kill the time, that had been discharged from the emergency room and essentially been given a clean cardiac bill of health. I don't think there was any deviation and not immediately sending her off to an emergent cardiac evaluation, which was the only option that day. If you really feel like it's that emergent, say, you need to go back to the ER. And if you don't want to go to that one, go to another one. That's the question. Did you expect that somebody should do that? So
that is a rough story. And terrible outcome. That was really hard to hear. And it does make me think, not at all to take away from the family and this young lady losing her life, but one thing we don't really talk about, we haven't really, is the outcomes for the nurse practitioner, right? Who was also part of this case. And let's say, lost, I don't know if that's the right word, but in that way. And how does that change you, right? Like I can only begin to imagine how that might change me as a provider and how I take care of my patients, or I don't. I mean, I think that those things can be really life-changing for everybody that's involved when we have these type of huge substantive outcomes like this that are really terrible sentinel events that happen.
Oh, for sure. I mean, I can't speak to how it affected that NP, although I'm sure that the personal emotional piece is much greater than, if you have malpractice insurance and if your insured just determines that a settlement is appropriate, they pay off the settlement. It's reported to the National Practitioner Data Bank. If there's a judgment against you or a case is settled on your behalf, it is reported to a national clearinghouse so that like if you apply for another job, then whoever queries the data bank will find that you contributed to a settlement. But there's so much of that. I mean, there's so much settled litigation that settles only because it's cheaper than actually going to court. So I don't know
Wow.
how many cases people settle and they really shouldn't have, but they do it because the insurer determines that, the risk, I don't know if
Yeah.
benefit's the word, but they try to assess risk. Like, so if we spend 2 years fighting this and finally get to court and the case is dismissed, but they have to pay attorneys to do all of that work. And sometimes they deduce that it's just more financially efficient to pay into a settlement and not have to spend all that time. So
Yeah.
for the insurance company, it's just financial expediency. But for the clinician, it is. I'm sure it has to be heart wrenching. You always, of course, go back and what could I? I mean, I've made goofs in my career. I made a goof. I mean, I don't even think she made a goof. I don't think this NP did anything wrong. I think it's just one of those examples where she did everything right, and there was just a horrible outcome that who would ever even have anticipated it. But I know in my own history, even having made a goof many, many years ago, and there was a pretty bad outcome. I mean, the patient did not die, but the patient had a rough course, and it was something that I missed. I mean, I didn't get sued. Like there were no repercussions on my license or anything, but I still will never forget it. I actually went back to the church that I grew up in, the Baptist church in Collingswood, New Jersey, and I knocked on the door of the minister's house. I'm like, I need to talk about this because I did this thing and this patient, all this happened.
Wow.
And I didn't even there wasn't even any official sanction to me. So I can't imagine dealing with the combination of the emotional piece and recognizing that, people contribute to settlements all the time, and it's not unusual for a clinician to have an entry or more with the nurse practitioner or the national practitioner data bank, but it still, has to, be like, dang, I wish that wasn't there. Every time you get malpractice insurance or apply for a new job, you have to explain it. Every time you renew your license with the Board of Nursing, one of the questions is, has there been a judgment against you? And then you have to address that. And so there is all of that too.
Oh my gosh. Wow. Well, I'm sorry that this didn't have a better outcome, but I
Mm-mm.
appreciate you sharing this story with us, Dr. Miller. And there was a lot to learn and process there. Thank you so much for your time. We hope you guys enjoyed. I don't know if that's the right word for this one, but listening to this, it was really interesting. There was a lot to learn. I think a lot of takeaways for all of us, quite honestly. So thank you for tuning in. And if you enjoy listening to these stories, check out some more that we got going on over here at Scrubs and Subpoenas. Goodbye for now.
Thank you for listening and learning with Scrubs and Subpoenas, Tales from the Witness Stand, presented by Fitzgerald Health Education Associates. Please rate, review, and subscribe to this podcast. And for more NP resources, visit FHA.com. Join us again next time as we dissect more medical malpractice cases.